Thanks very much, Leanne. I'm going to start off with a story. The story is of a sort of family friend called Michael, and I've used his story on and off over the last 18 months, and I said to him recently that this would be the last time I wheel him out in public. In 2011, Michael, he's a retired anaesthetist actually, was admitted to a metropolitan hospital in Australia. Initially went to the ward and then was admitted to an ICU shortly after about a sort of day or so on the ward with a diagnosis of sepsis. His specific diagnosis was pneumonia, and then was later on down the track turned out that he probably had cholecystitis actually. And he has some interesting recollections of his time in ICU, remarkably blurred actually, despite being someone who's bright and understands what was going on. Remembers, he thinks a central line being put in. He wasn't intubated at any point as far as I can tell. And remembers a discussion about a haemofilter, but doesn't think he ever had a haemofilter. But the fact that his memory is so blurred from it is actually is a story in itself. But at the time, and shortly afterwards, what I didn't realise about Michael is that Michael actually is our median patient. He is the most common admission to Australian and New Zealand intensive cares. If you look for the most common age, it's just under 65. They're more likely to be men, about 80 plus kilos, about 170, 175 centimetres, and sepsis is the most common non-elective diagnosis of admission to ICU. So Michael is a patient that we all recognise. If you look at 60-year-olds who are admitted to ICU across Australia and New Zealand, and you look at the mortality for those patients when they're admitted with sepsis, at a site level, it varies between 5% and 50%. It varies between 1 in 2 and 1 in 20. There's a huge variation. Now, most of that variation actually comes from the severity of illness of the patient. Not all of the variation comes from the severity of the illness of the patient. Some of the variation, and a minor proportion of it, and there are ways to quantify this, it comes from the processes of which you deliver within the intensive care. And the whole reason, the main reason for the ANZICS registry existing is to actually measure and delineate those differences so that we can compare how different ICUs work. But comparisons are difficult. And the reason why when we compare groups, we don't compare paediatrics with adults. We don't compare koalas with adults either. But there wasn't just a gratuitous picture of a koala in there. That's actually Sam the koala from the 2009 bushfires, who didn't die of burns. He died of sepsis, actually. He had chlamydial sepsis 6 months after his burns. And in true Australian fashion, 2 days after he died, he was stuffed and put in the museum where you can all see him today. So if we're going to compare groups, and if we're going to look to see where that variation comes from, we need to know more about our patients, and we need to group them appropriately. The ANZICS registries allow us to do this. They allow us the capacity to look at where that variation comes from. There are huge numbers of patients put into this registry every year. There's 130,000 patients put in annually. There's 1.5 million adult patient episodes in there right at the moment. And they allow us to quantify that variation. So I can tell you that about 15% of your chance of dying comes from how old the person is. Chronic comorbidities account for about half that. They're half as important. Acute physiological disturbance, biochemical disturbance, your BP, accounts for somewhere between 2 and 3 times that amount. Okay, it's 2 to 3 times more important than your age. It also allows us to look at some sort of slightly more unusual things, and this is some of the research work done by Manoj Saxena and Paul Young, looking at the relationship between temperature and mortality. And actually in septic patients, as your temperature goes up, your mortality goes down, if you compare it to 37. Now that doesn't necessarily mean that you have to warm patients up to make them survive. But it is absolutely, totally different from every other diagnosis that comes into ICU. So temperature in septic patients is a marker of a different process occurring. To work out whether intervening with temperature affects mortality is going to take the kind of high quality research just being presented to you by Sandy, the kind of work being led by Paul and others looking at interventional studies in sepsis and in temperature management. But I said Michael was our most common patient. This is how common sepsis is. And I've broken it down here with severe sepsis. So these are patients who meet SIRS criteria and have a diagnosis of infection. They're the sort of the larger cohort there. A subset of those are the patients who have septic shock. And then the sort of the bluish bars on the top are patients who have a diagnosis of infection, but by the time they hit ICU, don't have SIRS criteria. Now, some of those patients in ARISE would have been in that group because some of them arrived in ICU. They're the ones that Sandy was mentioning, who were the ones that went there for monitoring, and by the time they've arrived in ICU, they've been resuscitated. But the striking thing for me with this is that they might be the most common group. They're about 12% of our admissions. They're 13,000 admissions with sepsis in Australia and New Zealand intensive cares a year. They're increasing. They're not increasing just proportionally, they're increasing as an absolute number. This is a growing business for us. I almost didn't believe this when I see it, but every year this has continued, this trend has gone up. I was lucky enough to be involved sort of peripherally in some work that was done with the registry data some months ago by Maya Kaukonen and Ronaldo, which looked at the outcomes of sepsis patients, severe sepsis patients admitted to ICUs. And over the last 12 years, there's been a progressive decline in mortality due to sepsis. And even if once you adjust for everything that you can think of adjusting, or whatever way you want to look at it, or whichever group you want to look at it in, or whichever type of hospital, there is about a halving of the mortality for sepsis over this last decade. So this sort of really brings to the sort of title of the talk. Actually, this talk came about because Stephen Warrick phoned me up and said, Cathy Rowan can't come, we need you to fill in. And, okay, what do you want me to talk about? Tell everyone what we're doing right about sepsis. Well, if we are doing something right about sepsis, then absolutely the mortality should be going down like that, but we need to know how we compare to the rest of the world, and good comparative data is actually really very difficult to find. There's only two countries that produce national ICU mortality statistics publicly in this sort of way, and it's us. The UK has a similar but not quite the same sort of system. The US doesn't really publish this. Finland is about as close to a national publication. So there isn't really good quality data to compare with. So the best that we can do is compare with the trials that have been published. Sandy presented 90-day mortality of 18%. Their in-hospital mortality was 15%. Their Apache scores were 15, 16. The sepsis patients admitted to ICUs in Australia have Apache scores of about 18, have a mortality presently of about 18%. They're a similar type of group. We have outcomes that are at least as good as the patients in ARISE. The mortality in the process study, 19%. Same cohort, as close as I can estimate it, mortality in Australian ICUs, 18.5%. The Albios study, albumin administration in Italian ICUs, 19% mortality. Same criteria, Australian ICUs, 19% mortality. The French study looking at targeted blood pressure measurements in hypotensive patient, a sicker cohort, 25% mortality. Using the same criteria, we have 25% mortality for the similar type of patients. So our outcomes across the spread of our ICUs are at least as good as these high quality trials that are being done. This is something that we should be proud of. It doesn't tell us why this is happening. There are an awful lot of things that have been investigated. And I dug out as many as I could, and they've all gradually gone out of fashion. And now we see process has disappeared, and ARISE is making an early goal-directed therapy disappear, and we have promised left to give us a little bit of promise of something to come. So there are the magic bullets for sepsis are not likely to be the cause for the decline in mortality. And actually, if we look at it again and we put the decline in mortality for all of the rest of the patients admitted to ICU in Australia and New Zealand, those lines don't look parallel, but the proportional drop there over that 12-year period is exactly the same. It goes down from 35 to about 18%. It goes from about 13, 14% down to 8%. So this is a system-wide improvement that we're seeing. If this is a system-wide improvement, we need to look at why this is. When you look at systems in sort of the safety and quality land, they look at it in sort of three sort of ways. I've added in a fourth dimension here that we often use for ICU. So there's culture, access, processes, the things we do, and look at the outcomes. And I'm going to come back and look at what we do. So I decided, okay, let's look at the culture that happens in Australian ICUs. Actually, if you type the words Australia and culture into Google, it seems to take a little bit longer to come up with the answers. and after you've sifted through the pictures of Crocodile Dundee waving a knife on the New York subway, you come up with things like this. This is something called the power distance index. This is how much you perceive a hierarchy exists within your culture. Cultures that have a low power distance index communicate up and down the hierarchy well and communicate problems to people in power well. Okay, the country that has the lowest power distance index in the whole world is New Zealand. Australia's sort of a joint second. The highest countries are Russia, the Philippines. Malcolm Gladwell used this in his book when he talked about the ethnic theory of plane crashes, where there was a direct correlation between your power distance index and your ability to highlight a problem within the cockpit. The airline industry knows this well. The military people tend to know this well. The medical field is picking up on this, and where this has been looked at in medical literature, it appears that a low power distance index lends itself to better communication of critical problems and a safer healthcare system. So we're lucky because in Australia and New Zealand, because of the culture that we live in, we're primed for a relatively safe healthcare system, relatively compared to the rest of the world. But we have many other things. We have nursing ratios that standardise at 1-to-1. We have good nursing training. It was an eye-opener for me to switch countries in the early 2000s and to move from a system where I trained in the UK to Australia. You're aware of these differences. In 2005, there were only 5 countries that actually had dedicated ICU training programs. That's the reason why many of us come here. They were Australia, New Zealand, Hong Kong sort of counts as using the same one, really, actually. Switzerland and Spain. And we also have a system where critical care is not just delivered by intensivists. We have all aspects of critical care that are delivered by other craft groups within the ICU, outside of the ICU, in the emergency department. In parts of the country, we have paramedics that intubate. We have critical care that can be delivered and processes that deliver this well in many different aspects in different situations. So let's look a little bit at access. Do we have more ICU beds? Actually, if you look at number of ICU beds, really we're probably not that sort of different. US sticks out as having many more ICU beds than sort of hospital beds. Germany has more beds than anywhere else. And Australia and New Zealand sit sort of towards the line of the other countries, and there's a bit of variation, and there's quite a lot of variation in the way that people measure this that makes this sort of slightly dirty data to look at. But if we think of the growth in our ICU beds, over most of the 2000s, the ICU beds have grown at roughly the rate of population. The dark bars that you see on the right there are the actual beds as measured in Australia, plotted against the background population growth rate, which is about 1.5% to 2%. We have seen an increase in the last sort of 2 or 3 years. There's been a sudden expansion in ICU beds that isn't just greater reporting. So there is an expansion in ICU beds. So this doesn't account for all of those improvements. There are some more subtle things, though, that happen as we improve mortality, because people that spend a long time in the ICU, because people that die tend to spend slightly longer in ICU than people that survive. As you create more survivors, you also free up more days of care for other patients. In addition, the number of really long-term people that we have in our ICU, so patients that spend more than 3 weeks, is actually going down progressively over time. So we have an effective increase in access. And that effective increase has been seen by a number of, there's reductions in inter-hospital transfers, there's less refusals due to no bed, there's less cancelled elective surgery, measured by a number of groups. However, it's not all good news, and Dash Gantner's work shows this with after-hours discharges. If we had a great improvement in ICU access, we wouldn't be seeing the same amount of after-hours discharges, and we haven't changed the after-hours discharge rate across Australia and New Zealand in a decade, nor have we actually reduced the increased risk with after-hours discharge in a decade. It's still about a 30-35% increased risk with discharging someone at night. Now, there may be work coming from John Santamaria that will help shed light on this. So access isn't the whole answer. We are doing things differently. We're seeing more checklists, we're seeing more rounds with pharmacists, we're seeing more use of antibiotic stewardship, antibiograms, patient satisfaction surveys. Maybe that makes a difference. Airway competency standards. There's a limit to how much data there is about system-wide changes. One thing that we are doing that probably represents an improvement in practice is that we're ventilating less. And if you look at patients at every severity of illness range, we now ventilate a smaller proportion. So the furthest to the right are the highest Apache score patients, and each one of those bars in that 30-plus group represents the proportion of patients ventilated. It's going down. I would have never considered seeing a patient on VA ECMO awake 10 years ago. Now we routinely, in fact, we try and have them all awake and talking to us and not intubated. So we're ventilating less, and perhaps we're seeing less complications from ventilation because of it, and complications of sedation. And our outcomes are consistent. Our outcomes are consistent across the board. If you look at rural, metropolitan, tertiary hospitals, common diagnosis, overdose, pneumonia, sepsis, it doesn't matter where you go to, your outcomes are going to be the same. John Moran's work, looking at hospital volume in ventilated patients, there is no volume effect in Australian ICUs, Australian and New Zealand ICUs. Bigger ICUs look after ventilated patients as well as smaller ICUs. Each of those squares on the left is a tertiary metropolitan ICUs, rural or private ICUs. There is no effect. So I'm going to sort of just come back to the sepsis work, and I thought I'd have a little play, and I looked back into, normally when we present stuff, we only go back to 2000, but I dug out the data from the 90s. And there isn't really good stuff to tell us what we were doing differently in the 90s. So I had to ask around. And I phoned up everyone that I could think of that was doing in Australia in the 90s, and I interrupted people on their ward rounds, and I spoke to people at the board meeting earlier on this week, and I actually really did wake people up during their afternoon naps. And the kind of things that people said, and the common themes came up, a number of sort of like things that were considered good therapy, like transfusing to higher thresholds, ventilating with bigger tidal volumes, using supramaximal oxygen delivery targets. Those disappeared in the 90s. A number of standards got published towards the end of the 90s, including nursing standards, including recommendations for staffing units. Those happened. People started measuring things in the 90s. People started measuring what your refusal rate was. People started measuring what your outcomes were. And at the end of the 90s, one of the big things that happened, and no one specifically said it of the people that I talked to, but every single person talked about getting information back, which they didn't have prior to that. Unit outcomes started being reported back to the unit, so you could suddenly see where you were compared to everyone else. But Steve asked me to have a look at the future. Okay, so if I'm going to look at the future, let's look at what we're doing now. My friend Michael was admitted in 2011. Okay, over this time, the Apache scores of the patients with sepsis have actually gone down. However, their ages have gone up. The median age was 62 in about 2000, it's about 64 now. Not a lot, but gone up. The amount of comorbidities of those patients has stayed exactly static. It hasn't changed. It's about 35% have at least one comorbidity. What has changed, and if you remember at the beginning, I said that age accounted for a proportion, but more important, 2 or 3 times more important than age, was your level of physiological disturbance. The physiological disturbance of patients coming into our ICUs has progressively reduced. It's gone down most in patients who come from the wards. It's gone down a lot in patients who come down from ED, but not as much as it's gone from the ward, as it has done in patients who come from the ward. So presumably this represents, maybe we've changed our threshold for admission. Maybe we're treating them better on the wards. Maybe we're getting better resuscitation of the patients on the wards so that when they come in, they also get better resuscitation and measurements. That translates into better measurements when we finally do them in the first 24 hours of ICU. But again, it highlights that we deliver ICU care, and ICU care is given to our critically ill patients outside of the ICU. And I believe that it's our critically ill patients, our responsibility outside of ICU as well. But let's really look at the future. Now, this is playing, okay? This is me having a play around with the data. Here's sepsis. There's the mortality for septic shock. And for fun, let's just imagine you've got 45-year-olds who've got no comorbidities. So if you're going to pick a group in whom this was try and delineate the pure mortality attributed to sepsis by itself. Okay, let's pick some young people. That's what the mortality decline. All of these have declined over time. When I first looked at these, and I looked at this first actually after Michael had been admitted in 2011. I drew out some lines. If you draw a straight line through them, actually, all 3 of those lines hit 0 at about 2030. So if we carry on a linear decline, we can all pack up because there won't be any more deaths in about 2030. However, a better line of fit is to put a curve, an exponential decay curve. And this is where every single year has followed since then. So our decline in mortality is still following this decline that was there and was evident over the 2000s. And the implications of this for us are multiple. I think, particularly in the young, otherwise well, I think we should stop even thinking of sepsis as a condition that you die from. We should think of sepsis as a condition you should survive from. If the mortality at the moment is about 4% and is going to drop, we should be thinking of young septic patients as having a 97% chance of survival. We should talk about survival. Maybe we should even have them as critical incidents if someone who fits those criteria actually dies within our hospitals. It's going to be progressively harder for people to do studies. By the time you plan your study, you tend to look at the mortality a few years ago. By the time you implement it, it's another few years down the track. By the time that the study is completed, mortality has dropped. The power calculations that we use historical data. It's going to become progressively more difficult to look at mortality outcomes. As mortality outcomes get lower, we need to think about more other outcomes, functional outcomes. With this decline in mortality, actually, there's been an almost proportionately similar increase in discharges to rehab or chronic care facilities like nursing homes. Now, I can't separate out from our data whether you go to rehab and get better or whether you go to a nursing home, but it implies that there is more information that we need to know about the outcomes of those patients, not only from their functional outcomes when they leave ICU and when they leave hospital and when they arrive in wherever they arrive, be it a nursing home, a chronic care facility or their own home, but also the long-term outcomes, the long-term survival and the long-term functional outcomes. And those are the kind of things that become priorities for us, particularly when we have mortality that drops as far as this does. But we should be proud and give ourselves a little pat on the back that things keep going down. We should, if we don't continue along those lines, we should think that there's a problem. So in summary, sepsis is increasing, survival is improving. the care that we deliver in and outside the ICU is probably improving, and we need to start thinking about outcomes beyond mortality in future. Thank you very much.
David, thank you for a very thoughtful presentation. Have we got some questions for David? Jeff's coming down. I'll just might ask you again. It did strike me that the rate at which it's improving, and Sandy's trial was discussed in 2006. You'd almost expect a marked reduction in mortality by the time the trial's finished, wouldn't you? Just in the baseline, which makes it hard to really design the trial.
Yeah, absolutely.
Yeah.
In fact,
we might come back to that in a general discussion, because we've got some good people who might answer some questions on this. Jeff.
Thanks, David. It's always very provocative to hear these concepts. But I'm still wondering if we are prematurely patting ourselves on the back. If you think about it, death from all causes. Everyone dies of death, it dies eventually, but cancer survival is improving, cardiovascular survival is improving, and in fact, if you extrapolate back, the change was in 2000, so that the average person who's say 65 was actually born in 1935, so people born after about 1935 are all living longer, and our surgical techniques are getting better. So my question is, are we just seeing the effect of a better global health? And in fact, what we do in intensive care actually isn't making much difference.
Yeah, thanks.
Sorry, I'm just.
Your point is very, very well made, and the pat on the back that I suggested should be a very little pat on the back that goes beyond the ICU community and out into the medical community and the public as well. And I think it's a very valid point. I wish we had information that I could see it well measured to try and work that out. I think it's likely to be a very reasonable factor in the decline. I wish we could quantify it though.
David, you could make a comment too along the line that we've got pretty gross tools for talking about how well people are when they hit ICU. And I suppose, you've got the Apache chronic illness points, which there are 6 or 7 of them. You can use at Charleston or so, but I still think they're all fairly gross sort of tools at this stage and probably not matched to try and stratify the patients coming in.
Yeah, I'd agree with you. I mean, and there's probably a number of measurements that we could be looking at that sort of move things into a different domain. There's a sort of, I've heard it described as the crumbliness index, but there's actual proper measurements of frailty. Frailty is no longer a generic term. Frailty is a specific term which there are indices that move outside of our standard measurements of, biochemical instability and chronic health points for Apache, and those are independent predictors of survival, both at hospital and long-term survival after ICU admission. And the Canadians have done quite a lot of work on those, and they're just one example of the multiple different ways in which we could measure it, not only at the time when you come into ICU, but also at the time when you leave hospital and further down the track. That would probably give us a better handle on those kind of things.
Things on outcomes might be for the general discussion as well. So thank you very much, David.
Cool, thank you.